Of special interest at the Conference on Immigration and Health, held at Princeton University in May 2009, was the inclusion of successful initiatives and proposals which may be used as models to extend healthcare services. Participants reflected upon the creation of a comprehensive, efficient system that won't exclude the poor, the marginal, or the immigrant.
And looking at the FQHCs and looking at what works now, because one of the benefits of functioning in the shadows is that you have to do more with less and be innovative. And I think in some bitter irony, I think that we are learning how to do this the most efficient and most effective way we can with what we have. And I think one of the lessons that I've learned in my small perspective, in my small corner of the country, is that it's not going to be a solution of just FQHCs, and it's not going to be a solution of just free clinics. And what I would offer is that it's a hybrid of both fairly qualified health clinics at the community level that can put another flag up the flagpole and do free clinic care. There are burdensome and unnecessary restrictions when you take federal dollars that don't allow you to do free care, and I think that that's absurd. But if we're really going to make it work, we're going to take the existing brick and mortar infrastructure and we're going to be able to be federally qualified and deliver free care. Geographically, it makes no sense to have buildings that are the cornerstone of the care. I think we have to have mobile health to get into the fields, to get to places, because the population that's most underserved, that is moving around the country doing our hard work because we're not willing to do it ourselves, I think those folks have a hard time getting to the clinic.
This vision cannot work without stressing outreach and community support.
This is very different from the language we are hearing in Washington, that is more top-down, and rather than bottom-up.
And extending healthcare services is not just about including immigrants, whether legal or unauthorized. Other vulnerable populations will benefit as well.
American workers that are being laid off who do not have health care. More and more we're seeing that are laid off. These plants are closing. They don't have health care. We're seeing them in our centers, even in the private industry. Some of our doctors are saying, I've had this patient for 15 years and now he does not have insurance. What do we do? So basically, they've been putting almost these patients on a sliding fee also.
Not only federally health qualified clinics and CHCs and county facilities are taking care of undocumented patients, we are getting an influx of patients who had insurance. Because of the economic situation, we're having patients that are losing their jobs, losing their insurance. The COBRA is expiring. I have patients that drive 2 to 3 hours that had very good jobs, and because of their pre-existing conditions, they're unable to obtain other forms of health insurance, and they will go by no means to obtain that medical care through the county system as well as the federally health qualified clinics.
Ultimately, we as a people must decide what kind of a society we want. One in which fear and prejudice will leave millions far from access to medical care, thus creating risks for everyone, or a society in which health is viewed as a human right benefiting all of us.
That many of the restrictions that we face to these problems, not many, all are man-made. And so they can be man-made. The fact that you have to pay up front to see a doctor in FQHC is a man-made restriction. There is nothing necessary that it was. It is nothing. It did not fall from heaven. The fact that our migrant workers are clandestine and have to escape ICE in order to work for the equivalent of minimum wage or less. It's man-made. This also can be changed, and the question is how to bring, how to extend universal health care, but make it in such a way that in a sense, the people who have been operating in these clinics have been trying, sort of slouching to universal health care against many obstacles, and precisely because they are the ones who have tried, I think it seems that the experience which should be at the forefront of the legislation.
And then there is historical memory as a source of inspiration. Helen Marrow, a Robert Wood Johnson scholar in health policy at the University of California, Berkeley, said it best. Between 1935 and 1972, undocumented immigrants did have access to Medicaid, they had access to Social Security, they had access to a range of federal programs. As Marrow stated, I am thinking about all this in terms of the larger picture of our historical legacy. That this was once possible in an enlightened sense, that all residents in this great country can have access to these kinds of services and benefits and human rights. Our logic of restriction has blinded us to the fact that this was once a reality. By looking at our past, we can find new ways to fulfill those realities again.